Hello everyone. So this is part 2 of the stiff person syndrome episode because it's going to be an extremely long video. So we're going to talk about, physical therapy intervention or rehab intervention. Now, if you look at it, there's just very limited interventions reported in the research for SPS. If anything, they mention there's like case reports. But the most common interventions reported, and this was an article in 2019, is stiff person syndrome benefited by physical therapy intervention, summary of case reports. They reported massage, electrotherapeutic modalities, hydrotherapy, relaxation, and stretching, flexibility exercises, and balance. I want to add to that, just because we know that sometimes we don't focus a lot on massage or a lot of electrotherapeutic modalities. So I'm here to give you a little, what would I do if I would have someone with stiff person syndrome? The first thing that we need to know is what kind of things are they having trouble doing because of that stiffness and that rigidity, right? Because this stiffness and that rigidity will affect their ability to turn, their ability to walk, their ability to bend forward, their ability to move, because maybe they will present with range of motion deficits. I forgot the word. So we just need to assess, right? Get a true history of how is this affecting. Now, the other thing that we need to keep in mind is their gait will be affected at times because of this rigidity and that stiffness. They will have gait dysfunction and falling, history of fall. So you need to assess that. Stiff person syndrome can cause slowness in walking. It has been reported a certain kind of freezing or trouble with initiation of gait and, quote, statue-like appearance when they're walking, and unexpected falls due to that startle response by various external stimulus. Assessing their gait, thinking what is causing the fall, when do they fall. Maybe they can start a diary of the frequency of the falls, when do they fall. And of course, I would also, encourage them to keep a diary. This is something that actually the research says, keep a diary recording the frequency of the spasms and the occurrence of the spasms and the rigidity. 44% of patients with SPS are diagnosed with a specific phobia that is associated to a situation or a thing that might trigger their symptoms. So you can, imagine how this can be really debilitating. Those external factors and that internal factors are going to play a role in how they experience life, and their symptoms are triggered by these things. So we need to watch out. These people might get startled to acoustic and tactile stimulation. So I say that before you're going to work with them or touch them or make any sound, just be very careful to let them know before, so their body is already anticipating that sound or that touch. A startle response, it's very common to be present in someone with a sympathetic, like high sympathetic state. So I would really introduce autonomic practices. So again, I have not proven this, but I would try autonomic practices, grounding, maybe just things that will bring their nervous system into a more calm state. Any of those tools that you might have been exposed to or know, you can utilize to start stimulating that parasympathetic response, especially if they present with autonomic dysfunction. And the last thing that I want to mention is the phobias, right? The phobias are frequent in patients with SPS when walking among crowds, when walking in open places, in malls, in airports, in restaurants, crossing a street, anxiety, etc. So I would say if you have the opportunity, expose them to those situations in a way that you can promote a success, a moment of what they call it, a must by Mike Studer, moment of unexpected success in therapy. That way you build that confidence and you tap into that optimal a little bit, so that phobia can be diminished. If you can do that, I honestly don't know, but we can start giving them moments of success in those experiences if they allow us. Because remember, when there's a phobia, it's just a phobia, right? But maybe small progressive success through experiences until we reach a bigger success in therapy.
Now, here I just want to mention that I do not have awareness or knowledge about phobias. So, here I would just approach very carefully if the patient has a phobia. Um, that way, you're not creating more anxiety. But if the patient is open to try it, then you can try it. But definitely, if they just say that they don't want to do it, it's extremely scary, then I would say respect what they're saying.
And also, I would recommend to treat these people in just a calm room, not many noise, not many people. That way, they are less stimulated. So that's my own thoughts. You can try that again. I haven't proven this. This is just what I think. Going down the stairs or taking escalators also is scary for them. That unknown environment or that stressful environment. Now you can start recreating, right? Some things in therapy to kind of mimic those scenarios. I've seen it over the internet, people doing that. So again, you just need to be very careful of not overloading them with situations, because they already will come in a very sympathetic state, nervous, anxious, phobias, stress, right? So remember, stress, emotional stress is a trigger. So you don't want to overload them. You want to build it up, starting with a report, and then slowly exposing them to moments of success in therapy. Maybe, same thing, optimal, throw in some optimal, give them some autonomy since they've lost that control of when the muscle is relaxing. Give them that autonomy to choose things in therapy. Give them that control back in therapy. So those are a few of my recommendations. These are not from any article out there. These are just from my brain. I really don't know if someone has tried all these things. And the last thing I want to cover is turn on your orthopedic brain, because they're going to come in with lack of range of motion. You're going to come in with, contractures, things like that. So here is a good idea to talk to your orthopedic colleagues, and maybe they can teach you or give you a refresher of how to do a certain mobilization. And remember, when you're going to touch them, you need to warn them. That way they don't get startled with that touch, because tactile stimulus can be a trigger. So you need to touch them, asking for permission, and tell them, okay, I'm about to touch your arm. Here we go, or something along those lines. And then you can perform mobilization, working on stretching, flexibility, treating the impairments. But orthopedic and all the biomechanical factors will be pretty high on the priority list, okay? And then again, go back to treating the impairments, but don't forget about the autonomic optimal success, autonomy, all those things that are gonna make a difference. That was a long video, but I really hope this helps out someone. I haven't had the experience of working with someone with stiff person syndrome, but I think by reading the research and just making connections as a therapist, I'm able to feel less lost if I ever get to meet someone with SPS. So I really hope you enjoyed this video, and I'll see you next time.